we know that certain groups are falling through the net when it comes to accessing support. So why do I think this is? I think the key things are, first, we need to understand the nature of health inequalities and social determinants of health. We now know a great deal about them, but the risk is, whilst everybody is absorbed in the heat and burn of delivering day-to-day services, we can recite the problem, but we don't move on to enabling solutions. And I think, to be absolutely clear what we're talking about, if we look at National Institute for Clinical Excellence and NHS England, they say to us that health inequalities are systematic, unfair and avoidable differences in health across the population, but also between different groups within society. And I just want to make this come a bit more alive. So I travel to work on the tram, and my life expectancy is 4 years more than a woman of my age living at the other end of the tram line. I think critically, though, we don't pay enough attention to is the voices of people living with health inequality. They're often poorly heard or misheard, or if heard, they're not actively listened to and action isn't taken to bring about measurable change. But I think the good news is, if we can embrace it and stay cheerful, is the new structure of the health and social care system, the integrated care systems, has afforded us a real opportunity to make that change. Well, this is absolutely, literally vital. At the moment, I think we risk living in a lose-lose situation. We have to hold in mind, beyond the heat and burn of delivering services now, what is it do we want from medium and long term for all citizens, but particularly these people living in inequalities, particularly the children of today will be the adults tomorrow. And I think we have to understand what the task is so we don't get drowned by it. And it's about shifting the dial. And to do this, we have to find the headspace, resources, not mega resources. I think it's adjusting resources and the best way to enable individuals to lift out of health inequalities. What most systems and governments, and certainly the idea behind integrated care systems, want is to deliver and achieve a health-creating society. And to succeed across health, we need to achieve having more people, it's obvious, who are healthy and coping, and fewer who are struggling and unwell. And it's both the right thing to do for people who are living in inequalities. It's a human rights approach that we need to do this, but also it's the most likely way we're going to achieve cost-effective services. So we move from what we've got the risk of at the moment, a lose-lose situation, to a win-win. And put frankly, this is about social identity approach, providing social scaffolding for all, most of all for those living at the margins. And I'll try and again put flesh on the bones by making it come live. Being homeless and all the exacerbated risks this bring with it, with or without substance misuse problems, children and young people falling out of education and falling into the criminal justice system, where we know they have really high rates of mental health problems. I think the third big one, which I don't think we've done enough work on, we've just taken it in a very literal way, is living in social isolation. And we immediately tend to think of the elderly, but it's people of all ages. And there are different sorts of social isolation. And I don't think we've addressed these. And all those things compromise health and well-being. And when I went for my job at the ICB, there's a lovely director of public health said something to me that really stuck with me. She described this as people living in health inequalities. They're those people living in the dark corners of communities where we need to shine a light on them, which we sometimes do, but we do it in such a way that frightens them and they just go back into the dark corner. Mental health commissioners, I fully acknowledge, particularly have a very hard task now and into the future. But we have been given the opportunity through integrated care systems, whole system approach, to play this out really for the first time at place in localities. And that's where the answer's embedded. Using existing resources by closely aligning them to maximise benefit, working differently, strengthening the roles of different players along the pathway of care. And the two areas I want to highlight, which I don't think we fully utilise, as one as the voluntary sector, faith and social community engagement organisations, but also digital and AI. Digital mental health online platforms can play their part, and I think it's helping commissioners know where they can play their part. And I think the other thing is that mental health commissioners should turn to their physical health counterparts to say that there is mental health input we can give them to improve the outcomes of people with physical health problems. But we can't do it the way we've always done it, which is we're very nice people and we'll do it without resources. But if there was one thing that matters more than most, it's mutual trust. So listening to voices of these individuals, not passively, but actively acting on it, working alongside and commissioning at place, it's a strong lever to achieving this, using voices as an enabler to effective solutions that can be sustained, because it's no good without sustainability. We're social animals. We all want support from the teams we work with. We all want a bit of meaning and control over what we've been tasked to do in life. But we have to see this in the social reality of the way some people are expected to live. And it's just about shared social identity. So I think we all live in groups. We all love being in groups and shouting for the group. And I think this has been one of the protective features for those where there are still gross health inequalities in ethnic diverse groups, but they're strong together. So I think that's mitigated the risk, but there's still a lot to do. But the saddest thing I get is when somebody comes into a room and basically what they're telling me, amongst all the things that are going wrong, is they've no social identity whatsoever. Now, that is not human. So that leads to compromised health and well-being, particularly mental health. And worse than that is sitting in a room, as I did for years, with young people with mental health problems who were offenders. And they'd say, well, it's all right for you, miss, because I was always called miss. But, you know, it's what am I to do? Nobody offered me the help I needed. I needed to feel safe. So you don't like it, I'm in a gang because I might harm others or be harmed myself. But I'm 50% safe in a gang. So what they'd gone and joined, because we weren't offering them what they needed, was a toxic social identity. And we need to be better able to understand the ways of being of people with health inequalities and actually stretch our imaginations about ways of seeing of how to help them.